oxygen. Conversely, if the pH goes higher, so we're not acidic, we're now basic or more alkaline, take that same 30 millimeters of mercury, follow the dashed line up to the blue line, look what happens to your body's ability to bind oxygen to its hemoglobin. It goes up, right? So pH plays a big role in your body's ability to bind oxygen to hemoglobin. Okay? The more acidic, you're going to have less binding of your oxygen. The more alkaline, the greater ability of your oxygen to bind to hemoglobin. Okay? That's how we read this graph. What else do you think can affect your body's ability to bind oxygen? You have a change in pH. What else? Think of what else might affect your body's ability to bind its oxygen. What other process might happen in your body? Temperature changes. Okay? Fevers. Okay? Same thing. We have the black line, which is normal body temperature. So in 37 degrees centigrade or 98.6 Fahrenheit. A higher temperature, which means a fever. Okay? Same thing. Your body to bind its oxygen diminishes. Versus if your body temperature drops a little bit, okay, you kind of conserve and hold on to that oxygen, so you're able to bind it to its hemoglobin more readily. Yep.
So when the temperature drops, your body's gonna hold on.
It's going to hold on to its oxygen, so therefore it'll bind to hemoglobin more easily. Versus if your body temperature goes up, okay, you're expelling a lot of your oxygen out, right? Things start to go faster with your body temperatures up higher. Okay, your respiration increases, you start to sweat, so therefore you're using up a lot of your oxygen. Therefore, it doesn't have time to bind to the hemoglobin inside your red blood cells. So therefore, its ability to bind becomes less. Go back for a second, the analogy. Somebody ran that marathon, right? The heart's ability to fill up briefly becomes diminished because your pressure is so high and blood is circulating, the heart is working too fast. It doesn't give time for those atrium to fully fill up, to make the ventricles fully fill up. So the same thing. If your body temperature is increased, all of your metabolism is increasing, circulation is increasing, you're using up your oxygen so fast, it doesn't have time to bind to hemoglobin. Versus if you drop your body temperature, what's happening to things in your body? They're slowing down. Okay? Your respiration slows down, your circulation goes down, so therefore the oxygen can stay in the blood longer, so it can bind to hemoglobin longer, so therefore your blood becomes more saturated with oxygen. Doesn't mean it's the best thing for your body, because hypothermia can end up killing you, but at least you'll have your oxygen in your body for a while until other things happen as a result. Okay? Even changes in the pressure of CO2 can affect your body's ability to bind oxygen, right? Because obviously if you have high CO2 levels in your blood, you have to have what? Of oxygen? Low. Okay? So therefore, somebody decides they want to hold their breath. Okay? Okay? What's happening? Levels of CO2 in your body are starting to become higher and higher, and you're having less oxygen, right? Until eventually you take that breath. So that's changing your body's ability to become saturated with oxygen. Okay? So we understand the premise of this saturation is body's ability to bind oxygen to hemoglobin. Okay? All right, so So now we get to an area very similar to what we have in the brain. We have what are called the respiratory centers. Okay? Just like we had our cardiovascular center, right? Cardiovascular center helps us receive different input from different receptors, from maybe your cortex, and then as a result would give out either parasympathetic or sympathetic stimulation to tell your heart to either speed up, slow down, vasoconstriction, vasodilation. Okay? So here in the respiratory center, the area of the brain from which nerve impulses are sent to respiratory muscles is located in the reticular formation of the brainstem. Okay, so if you look, it's the medulla, it's the pons and midbrain. The center consists of a medullary rhythmic area, where you have inspiratory and expiratory areas from it. So this medullary rhythmic area, which would be this entire area here, and there are going to be an inspiratory and expiratory area. So that will help us in telling us when to breathe, when not to breathe, when we should take a breath in, when we should expel a breath out. We have a pneumotaxic area, more superior in the midbrain, what's called an apneusic area. Let's take a look at the medullary rhythmic area for a second. Once again, that's in the medulla, so that's very close to that cardiovascular center. Okay, so you can see brainstem damage, is going to cause cardiac issues as well as respiratory issues. That's why people with brainstem injuries need to be put on a ventilator. Okay? So in the medullary rhythmic area, that's the area that's going to control your basic rhythm of respiration. Okay, the inspiratory area, that little superior circle, has an intrinsic excitability of autorhythmic neurons that set the basic rhythm of respiration. Okay? Once again, aren't your lungs autorhythmic? You need to say, it's time to breathe. No, it does it by itself. Okay, that inspiratory area is where that comes from. Just beneath it, in the expiratory area, has neurons that remain inactive during most quiet respirations, but are more active during high levels of ventilation to cause contraction of muscles used in forced expiration. So, when you run, work out at the gym, when you need to really expel out that carbon dioxide, that's when that area will kick in. So normally at rest, it's not active. Right? But when you need it to kick in, it does. Okay? So we need to really expel out all that carbon dioxide. Let's look up higher in the respiratory center, that pneumotaxic area, okay, which is up in the midbrain. Okay? It's not really the upper pons, it's more of the midbrain. It helps coordinate the transition between inspiration and expiration. Now, when you take a breath in, there's like a brief pause before you breathe all that air out. Right? Take a breath in, and then breathe it out. And without you holding your breath, there's a little bit of a pause. Just like there's a little bit of a pause between contraction and relaxation of the heart. Okay? It could be a millisecond, but there's like a brief in between stage. Well, that's that pneumotaxic area. That's going to tell it, okay, you're done taking a breath in, okay, let the breath out.
So the pneumotaxic area is where it pauses for the contraction.
Well, that pneumotaxic area will basically set that duration of the pause.
Okay.
So basically, you've taken your breath in, but now you got to let it out. So it'll kind of kick in to say, okay, let your body breathe it out. Even though it's autorhythmic, it comes from that area. Okay? The apneusic area, okay, sends impulses down into the inspiratory area. and as it sends impulses to the inspiratory area, it has to inhibit the expiratory, right? Because you can't breathe in and out at the same time, right? Like your heart contracts, then it relaxes. Contracts, relaxes. But it can't do both at the same time. It would be physiologically impossible because you need blood to go from atrium to ventricle, okay? So same thing, you gotta take a breath in, but you can't have, or similarly, you can't have biceps and triceps contracting at the same time unless you're doing what we call an isometric exercise. Okay? If you're trying to flex your arm, you can't have the triceps trying to extend your arm. Okay? So that comes from the apneusic area. So as you're taking a breath in, it kind of shuts down that expiratory area. Now, what can affect your respiratory center? Okay? Things that can affect the respiratory center are very similar to what can affect that cardiovascular center. You can have cortical influences, cortical means the brain. Okay, so you can have impulses from the brain that allow conscious control of respiration, that be needed to avoid something that doesn't smell good. So you go into a room, you're like, oh my God, this smells horrible, and you like don't even want to breathe. Okay, that comes from your brain. You deciphered that something has a bad odor to it, you don't want to breathe in, and you kind of hold your breath until you can leave the room. Okay? Now, breath holding obviously can override your normal respiration. But when you hold your breath, what's increasing? You're increasing your CO2, and it's also, by increasing your CO2, you're also changing the body's pH. Okay? And you're getting more hydrogen ions, which would make your blood more what? Acidic. Okay? So, if you try to hold your breath, or you go in a pool and you can see who could hold their breath the longest underwater. The reason you have to eventually take a breath, okay, not because you're gonna die, is because you have so much buildup of carbon dioxide that your body is kind of forced to come to the surface to get air. It's not the lack of oxygen, it's the buildup of CO2 and the drop in pH in your blood, which causes you to have to eventually go to the surface, okay? Because too much CO2 in your body is actually very harmful. You gotta expel it. Okay? Just like with the digestive system, you gotta get rid of waste. Okay? And in the urinary system, you gotta get rid of waste. Waste is toxic to our bodies. Okay? So if you hold your urine too long, okay, you're more susceptible and prone to infections. And you gotta get rid of it. When it's time to pee, it's time to pee. Okay? You can also have chemical regulation of the respiratory center. Okay? Remember we had receptors, we had chemoreceptors, we had baroreceptors, okay, which gave us changes to the cardiovascular center. Well, here we have chemoreceptors located in the medulla, as well as peripheral chemoreceptors located in your arteries. Okay, so between the two, we have chemoreceptors which are detecting changes in our body's oxygen and carbon dioxide levels, as well as pH levels, okay, which can tell your body when it needs to either increase its respirations or decrease its respirations. Okay, once again, you can have an increase in hydrogen ions and an increase in pressure of CO2, which would cause you to want to take more breaths. Now, what if your body's has what's called oxygen deficiency, or what we call hypoxia? Okay. Hypoxia, yeah, Anna says that. without oxygen. Hypoxia refers to oxygen deficiency in your tissues. Okay? So oxygen deficiency in tissues can be classified in a bunch of different ways. One is that you have a low pressure of oxygen in the arterial blood. That can be due to high altitudes, an airway obstruction. You can have fluid in your lungs. So if that's the case, not having enough oxygen to your tissues can eventually cause death to certain tissues, especially the brain. Without the oxygen, the brain will die. You can have an anemic hypoxia. Okay? There's too little functioning hemoglobin in the blood. So if you don't have hemoglobin, you can't find oxygen. You can't find the oxygen, you can't travel in your blood. Right? Because we know that at least 98, if not more % of your oxygen travels as oxyhemoglobin. And how could that happen? Bleeding, hemorrhaging, you can be anemic, okay, or carbon monoxide poisoning. Okay, too much CO, not CO2, too much CO in your blood. You can have what's called a stagnant hypoxia. And with that, your body has the inability of its blood to carry oxygen to tissues fast enough. So it should normally take a certain amount of time for your body to circulate its blood. So therefore, oxygen should be able to circulate throughout your body in a certain amount of time. But what if you have heart failure? So the heart's not working as strong as it should. It's not pumping as fast as it should. Okay, so there'll be a decrease in the flow of your oxygen levels, right? Because your blood's not circulating. You could be in shock. Okay, so once again, oxygen doesn't circulate fast enough. And last thing, you can have what's called hystoxic shock. Okay, blood delivers an adequate oxygen to your tissues, but they're not able to use the oxygen that they get. Okay, very similar to what endocrine disorder, where you can make a certain hormone, but you can't use it. Come from your pancreas. The diabetes, right? Sometimes it could be that you make enough insulin, but your body just can't use it. Or it could be due to the inability of your body to make the insulin. So then, same thing. You're taking in the oxygen, it's being circulated, but for whatever reason, okay, the tissues can't uptake the oxygen. Proprioceptors. We saw that also in the cardiovascular center. Remember, we had our baroreceptors, our chemoreceptors, and we had our proprioceptors. So proprioceptors of joints and muscles activate the inspiratory center, okay, to increase your ventilation prior to exercise to induce the oxygen need. So your body knows when it's getting ready to do something, preparing itself, that it needs more oxygen. Okay, so your body's receptors enable it to do so. Now, we also have an inert reflex in our body which will prevent our lungs from overinflating. Okay? Picture the lungs as a balloon. We're filling it up with air, we're filling it up, we're filling it up. What's going to happen to the balloon if we just keep blowing it up? It's going to pop, right? It's going to burst. If we did not have this reflex, your lungs would do the same thing. Okay? So in lung tissue, okay, we have receptors, okay, called stretch receptors, which respond to the tissue of the lungs being stretched as they fill up with air. Once these receptors become stimulated because your lungs have reached a certain capacity, this reflex kicks in. It's called the Herring-Brewer reflex. Okay? So once again, these receptors are located in the walls of the bronchi, bronchioles, and in the lung tissue. So when the lungs are stretching, these receptors become stimulated, and they prevent overinflation of your lungs. So you have like this built-in mechanism to say, okay, we have enough air, now we need to let it out. Because otherwise, if we kept it going, eventually lung tissue would become damaged, and eventually you might burst a lung. So we have this reflex to prevent that, this Herring-Brewer reflex. Along with the receptors that we have the vagus nerve that will help in this mechanism. And we have all of these respiratory center areas helping out as well. So between all of these areas and our different receptors, we have a built-in mechanism to help you breathe normally, set a specific respiratory rate, right? Isn't part of vitals, we take pulse, we take our respiratory rate, okay? So we have our standards, okay? And somebody might be nervous, their respiration might be a little increased, or if they're a seasoned athlete, it might be a little more decreased, okay? But that's how this respiratory rate becomes established from all of these areas that are in our brainstem, nerve stimulation, as well as other receptors. Now when we exercise, okay, the respiratory system is going to work hand in hand with the cardiovascular system to help make appropriate adjustments for the different exercises and different intensities of the exercises we're going to perform. Okay, so as we perform our certain exercise, depending on how long it is or how hard we're working out, okay, we're going to need different changes in blood flow. We're going to have changes in gases. Okay, so as we're using up a lot of oxygen, we're producing more and more carbon dioxide. So as blood flow increases, lower oxygen and higher CO2, the amount passing through the lungs increases. Therefore, ventilation between your oxygen and carbon dioxide capacity becomes greater. So once again, your cardiovascular system has to work hand in hand with the respiratory system. Okay? It's how we're getting our oxygen through our body, how we're getting our carbon dioxide out of our body. If somebody is asthmatic, okay, asthma is characterized by the following. You're going to have spasms of smooth muscle in the bronchial tubes. Now initially, the trachea is a lot of cartilage, right? We have those C-shaped rings of cartilage. As we move down that bronchial tree, we get less cartilage and more smooth muscle. Okay? And by getting more smooth muscle, we can control constrictions and dilations. So what happens with somebody who's asthmatic? They need what? Bronchodilators. Is cartilage going to dilate? No. So therefore, you can dilate muscle, right? Muscle can relax, and therefore it can make a wider opening. So because we have this smooth muscle down in the lower structures, okay, it can go from constrictions to dilations. Okay? So it can be characterized by spasms of smooth muscle in the bronchial tubes that result in partial or complete closure of the airways. There could be inflammation causing asthma, inflated alveoli, a lot of mucus. Okay? Common triggers for asthma are allergies. They can be emotional. Okay? Aspirin can induce some type of asthmatic attacks sometimes. Certain exercise, cold air, and even cigarette smoke. Okay? And for those that are asthmatic, you might know already that this can almost feel like you cannot breathe. So you might have to have certain medications available, sometimes you might be rushed to the hospital. Okay? Just feel like you cannot catch your breath. You can have what's called chronic obstructive pulmonary disease, COPD. COPD is a type of respiratory disorder characterized by chronic and recurrent obstruction of airflow. Okay? If we're obstructing the airflow, or we're narrowing the openings, just like in a blood vessel, what's happening to resistance? It increases, right? So airway resistance increases because we're narrowing the opening. Not a lot of room to go through, so things end up rubbing against the walls of things, whether it's in the blood, whether it's in your airways. The principal types of COPD are emphysema and chronic bronchitis. A lot of the symptom is this productive or mucousy cough that you get. You may get lung cancers. A lot of times the bronchial epithelial cells get replaced with cancer cells, especially after constant irritation. Once again, irritation can be smoke inhalation, irritation can be other chemical irritation. You know, you breathe in certain chemicals, it can irritate the lungs, it can even burn the lungs. You may have a pneumonia, okay, which is more of an acute infection of the alveoli, so all the way down to those tiny little grape-like structures, which may be bacterial or viral in nature. So it may involve antibiotics, obviously if it's bacterial. You may need bronchodilators, okay, to open up those airways. You may need oxygen therapy, or what they call chest physiotherapy, where you might pound the hell on somebody's back or chest to try to loosen up a lot of that mucus so they can get it out of their body.
What do steroids do?
Steroids take down inflammation. TB, okay, inflammation of the pleura and lungs, okay, produced by different bacteria. TB tends to destroy lung tissue, leaving it non-functional and fibrous. Okay, remember that picture that we looked at? That brief slide, I said this was normal lung tissue, okay? So with TB, sometimes you tend to destroy that normal looking tissue, more fibrotic, so therefore it's not as elastic. So it's not as elastic, you can't take good breaths. Okay, because your lung tissue is elastic just like your arteries. The common cold, okay, caused by a virus. Most of the time, you don't have a fever, okay, but you may. Whereas if you have the flu, which is also viral, okay, you might have a fever that exceeds 101, or you can go up to 103, or sometimes even higher than that. But either way, viral. Gotta run its course. No antibiotic in the world is gonna cure you. Okay. Pulmonary edema. It refers to abnormal accumulation of interstitial fluid in the interstitial spaces and alveoli. Okay. Maybe pulmonary or cardiac in nature, so therefore it could be a result of poor lung or poor heart function. Cystic fibrosis. Okay, with cystic fibrosis, okay, an inherited disease of your epithelial cells. It affects the respiratory passageways. It can affect your pancreas, salivary glands, sweat glands. Once again, you get these cysts forming inside lung tissue. Once again, they become fibrotic. Therefore, the lungs cannot perfuse your oxygen and carbon dioxide readily. The tissue cannot expand and constrict the way it should. So therefore, you're not getting a lot of circulation of your oxygen and a lot of elimination of your carbon dioxide. And then lastly is asbestos. Okay, you can have breathing in asbestos causes lots of damage to the lung tissue, causes different cancers. Okay, a lot of old-time schools and colleges were made with a lot of asbestos. Now they've pretty much gotten rid of a lot of the asbestos in those buildings, so they're gonna shut them down. They've had to wear specific suits and masks so that workers don't breathe this in. Okay? And then one last thing would be the sudden infant death syndrome, okay, where you have your apparent healthy child, okay, and then they eventually just stop breathing. Okay? They don't know why. Usually happens in babies under a year old, or even less than that, like under 6 months. Okay, but they do know that positioning of the baby has a lot to do with it. Therefore, babies are supposed to sleep on their back, okay, to start until they are able to turn. So you're not supposed to put an infant down on their stomach to go to sleep by themselves, okay? But if that 3-month-old, 4-month-old can turn from their back to their stomach and vice versa on their own, then they usually say that the chances of them getting SIDS drops significantly, okay? They don't know why it happens. It happens in certain populations, it happens for unknown reasons, but they have not been able to pinpoint this is a specific thing, other than possible positioning of your baby can add to that. Right? All right, so that takes care of pretty much our respiratory system. Okay, it's a lot.
Any more slides?
No. So there's a lot of material in this chapter. Go back, look over the packet, at the same time, look at the slides that go with it. Make sure that you understand the concepts that we went through. Look at gas laws, spirometry graph, right, how oxygen and carbon dioxide transport through your blood system, okay, how the pressures of each of the gas affect saturation, what else affects our saturation. Okay? Don't worry about that one slide on how oxygen and carbon dioxide actually change. I just wanted to show you how it does happen in your body, but that's just to show you, so don't worry about this slide. You don't have to study it and worry about each chemical reaction. But just know that oxygen, okay, in order to bind to hemoglobin, has to go through a series of reactions. Carbon dioxide, in order to turn it to bicarbonate ions, has to go through a series of reactions and then get back into carbon dioxide through a series of reactions to be expelled from your body. Next class, next week, we have to go through the digestive system. So it's a pretty lengthy packet. There's a lot of information that we have to go through, and then we have to review at the end of class for test number 3, which is only on these 2 chapters, respiratory and digestive only.
Just like the other one, it's only on.
Yeah. So 2 weeks from today is your 3rd test. Because after that, we finish up with the last 2 systems and then the last test. Right? When's your break? It's December 13th, you're done with lecture, and December 18th, you're done with.
Well, we have like 2
Lab.
days for everything.
Right? So December 18th at 7:32 is your break. All right?
Still doing it.